following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
Welcome to Doctors on Call. Tonight's topic, brain issues. Two experts are here to answer your questions. Now here's your host, Dr. Joe Perdome.
Good evening. Our brain is quite the juggler. It controls how we think and feel, how we learn and remember, and how we move and talk. But an unexpected event like a stroke, a brain tumor, or epilepsy can change all of that. What can we do to protect our brains from one of these life-changing conditions? Who's most at risk for having a stroke? Are there treatments to reverse the effects of epilepsy? We'll get the answers to those questions and more tonight from our two guests, Dr. Julian Bales, a neurosurgeon whose special interests include stroke and neurosurgical oncology, and Dr. Christopher Nance, a neurologist whose specialties include neuromuscular diseases. If you'd like to ask a question, give us a call. Our phone lines are open now. Julian, let's just start with the most common condition, stroke. If I'm with somebody that's acting funny, how can I tell if it's a stroke?
You know, when a stroke occurs, the whole brain ordinarily doesn't go out. It's part of the brain. So you lose part of the brain's function. And typically that is either blindness in one eye, or inability to move, or numbness on one side of the body, or inability to speak. So that's the typical thing. Now there can be variations of that, but that's what we usually see.
And how long should I wait if I see one of those before I take that person to the ER to check it out? Not very long, right?
You shouldn't wait at all. You should call 911 if there's any doubt. Let the doctors and EMS squad sort that out at the emergency room. That's the thing. We say time is brain, and that's why you want to get moving if there's any suspicion.
So even a few minutes makes a difference?
It absolutely does.
All right. Let me ask you something, Chris. If a person has a single seizure, does that mean they have epilepsy? I know you're an epilepsy specialist.
No, it does not. Epilepsy is defined as by having two or more unprovoked seizures. So having one seizure does not mean that you have epilepsy. Seizures can be caused by multiple things: head trauma, drugs, strokes, and they can be inherited genetic conditions. So one seizure doesn't, but when you start having two or more unprovoked seizures, that's what the definition of epilepsy is.
All right, so epilepsy is just one of the things that you do. You do neuromuscular diseases. Tell me the names of all those so our callers will know what you actually treat.
Neuromuscular disease is a broad topic, but it has to do with such things such as myasthenia gravis, Guillain-Barré, Lou Gehrig's disease, or what we call ALS in the medical literature, Charcot-Marie-Tooth. It's a broad topic.
Okay, so lots of different things.
Mm-hmm.
Now that's kind of interesting because one of the things that Julian treats a lot and knows a whole lot about is concussions, and some of the things that happen after multiple concussions look kind of like some of the things that Chris was just talking about, the ALS and the Parkinson's. Can you draw a pattern there or tell us how that happens?
Well, you know, the classic case that people talk about is the great boxer Muhammad Ali, how he has Parkinson's disease now, and I think no one really knows, was that from having too many blows to his head? But a certain amount of brain degeneration is from multi-trauma, particularly the so-called mild traumatic injury or concussion, which nowadays we think is not mild at all in many cases. So certain cases, and there was a recent report that maybe Lou Gehrig didn't die of Lou Gehrig's disease, a small report of 3 patients from Boston that they said that is actually from brain trauma that he and the others sustained when they were younger. So I think there's more and more we're learning about that now.
That's really interesting. I want to come back to this concussion thing, but we do have a call waiting. We got Lee from Harrison County. Lee, give us our first question for tonight.
I have a small tumor next to my brainstem, and I was wanting to know how fast something like that would grow.
Can you tell us any more details about that?
It's about 2 centimeters, I think.
How long have you had that tumor?
Probably 5 years. I don't know. I'm not sure.
Dr. Bales, any other questions you want to answer?
I didn't hear, what kind of tumor is it?
It's just a fatty tumor.
Yeah. A fatty tumor is often very benign. It's not cancerous and often doesn't grow. And many times nothing needs to be done about them. We often don't take them out. They're kind of a big glob of fat just sitting there and not expanding and pressing on the brain. So fatty tumors are often, if you had to have one of the best to have.
That's good for Lee. So how soon should she probably get that rechecked to see what's happening to it?
You know, unless Lee's having symptoms, probably once a year with an MRI scan, something like that.
Wonderful. Well, Lee, hopefully that information helps you. Thanks for the call. Let's talk a little bit more about concussions, because there was just a spot on the radio about a study showing that concussions are at least reported 2 or 3 times more commonly in junior high and high school athletes than they were 10 years ago. You think that's real, or is that just we're noticing it now?
Well, I think you're right. I think we're noticing it now. The doctors know more, the parents, the athletes, the coaches know more than ever. And it's said that there's been more research about concussion the last decade than there ever was before. We know now that concussion is not just the brain not working right, that there is the chance that there's torn fibers. Most of the time the brain heals itself. But the rub comes in where if someone gets a second or third, multiple concussions before the effects of the first one has healed. I think the brain tries to heal those torn fibers. I think it does in most cases. But that's why we and others have been very aggressive about alerting to the potential long-term damage if not managed conservatively.
So maybe that second or third concussion causes scar tissue to form instead of repair or something like that?
Exactly.
Interesting. We've got Bob on the line from Wood County. Bob, tell us your question tonight, please.
Okay. There's 2 things in my head. Okay, one of them I've had worked on, the other I didn't. I had a arachnoid cyst in the back of my head, pushing up on the cerebellum. And they put a shunt in, I can't remember the name of the shunt, put it in 98. And Dr. Gold put that in down here in Parkersburg. Anyway, the question is, only one side got drained because there was a membrane in between them, which they didn't know. It was 2 separate arachnoid cysts. And the shunt only took care of one side. And then it wasn't about 3 years after that, the tubing came out of the shunt, and the tube went down into my stomach, in which I had it removed out of my stomach. It was blocking off my intestines. I didn't know whether that's possible or not, but it sort of seemed like for that. Couldn't go there. And then the second question is, on the small tumors in the center of my head, it sort of had an effect on hearing on my left ear. I don't hear nothing on my left side. On enough that tumor can affect the hearing on one side.
So let me make sure I got your question straight, Bob. The second one was, can a tumor affect the hearing on only one side, if I understood right? And the first question is...
Yeah.
The second question was, or the first question was, if you've had this shunt and you've had it malfunction, do you need to have something else done about these arachnoid cysts? Was that your first question?
Should I have seeing how it ain't draining properly.
Right.
Now, which it used to. And there's still another shunt in there. It's never drained. I mean, another arachnoid cyst, pocket of blood. Should I have that blood stay there? But if it doesn't affect me right now, just leave it alone.
I think I understand your question. Thank you. Anything else, Julian, that you need to ask?
Well, my advice would be to leave it alone. Now, you could talk to Dr. Gold. He's a very well-known and accomplished surgeon. He knows the particulars. But a lot of times these cysts will form a membrane like he's describing, and part of it will have two chambers then. So to start working on that and putting multiple shunts in is sometimes becomes chasing your tail. So I think unless you're having really a lot of symptoms, I wouldn't do it. I think I'd leave it alone. And the second question, certainly tumors near the inner ear can affect hearing. The classic one is the acoustic neuroma. and those can be treated with surgery or sometimes radiation treatment like a gamma knife, and many times they're just observed.
I think part of his question too was if one is near the center, why would it only cause hearing loss in one ear instead of both? Is it still possible in the center to be responsible for loss in one ear?
It could. It depends on the exact location and what side it's preferentially pressing on, perhaps.
Well, Bob, good luck for that. It sounds like you got a good surgeon, and so you should direct those questions to him. But all of it sounds like is doing well right now. We wish you good luck. Our next caller is Linda from Jefferson County. Linda, what's your question for us tonight?
Yes, I'm on a low-dose aspirin, 81 milligram, and I also take Celebrex for arthritis. And is that too much aspirin, taking the Celebrex also?
Got it. You want to take that one, Chris? The Celebrex combined with low-dose aspirin?
Yes, depends on what you're taking it for. Celebrex is not proven to treat heart disease or stroke, but low-dose aspirin is. So a baby aspirin is fine. What you need to be worried about when you're taking both a baby aspirin and Celebrex is your stomach, because both of those can cause bleeding conditions in your stomach. So if you were to notice, say, black stools, or you were to notice blood coming up, then that would be something to worry about, because those can both eat the lining of your stomach.
Got it. But the Celebrex would be one of the safer ones if you're going to take a medicine of that type, a little safer than the Motrin or the Aleve or Advil, a little less bleeding complications with that one if you're going to take one of those types of medicines, right?
Correct.
Perfect. So, Linda, if you have to have one of those types of anti-inflammatories, that's probably the safest combination. But watch for those side effects, and thanks for your question. All right. I was interested, Chris, that we were talking about concussions and the side effects of concussions. Do you think that many of these conditions that you see are caused by the sequela of brain injury, or do you feel like that the ALS and the Parkinsonism are mainly genetic and not related to events?
Well, with the ALS, we really do not know, or Lou Gehrig's disease, what is most properly known. We don't really know what the definite cause is of Lou Gehrig's disease. We know that about 10% of Lou Gehrig's disease is genetic, but the other 90% we're really not clear of what causes it. Could it be environmental? Could it be genetic? Could it be some virus that you catch as a kid? We're not really sure. Could it be a combination of several things? Now, the study that we hit on previously about head trauma is interesting. It was a small study, but I don't want to jump to the conclusion that the 90% that we don't know about is all head trauma, but it could be a precipitating factor in some cases, and it's worth doing more research into.
And how about the Parkinsonism or the pugilistic type Parkinsonism? Is that very common, or do you think is those two separate entities that you can clearly distinguish, or is that also an overlap that may be related?
Parkinson's disease is usually a genetic degenerative condition, which we don't know the cause of in lots of things, and it's probably multifactorial, and there's lots of studies going on about what exactly causes Parkinson's disease. Most people that we see do not have Parkinson's disease due to head trauma. It's just what we call idiopathic Parkinson's disease, but there probably is a significant link there between head trauma and the development of Parkinson's symptoms. Whether you want to classify it as idiopathic Parkinson's disease, but they're very similar conditions.
All right. So let's switch gears a little bit here and talk about the different types of strokes. We talked about stroke just briefly. You think you're having a stroke, get to the hospital. There are actually two kinds of strokes, though. There's one stroke where you bleed and one stroke where you don't get enough blood. Julian, tell me about the difference between the two. And what needs to be done.
The most common is very similar to a heart attack, where the main artery, a part of the brain, gets a clot inside of it, and it shuts off. So that part of the brain beyond there doesn't get blood. And that's about 70%. 30% is where something leaks in the brain, and there's a blood clot that forms. And that's common with people who have had uncontrolled or poorly controlled high blood pressure for years. It's common with things called brain aneurysms, which are a weakness in the wall of the artery, which decides one day without provocation to rupture. So those are the common types of hemorrhagic or hemorrhage strokes, which make up 30%.
So a little different. Maybe we can get back to how those are treated in a minute. Right now I got Mick on the phone from Greenup County, Kentucky. Mick, what's your question for us tonight?
Well, my daughter is a physician herself. She's 41 years old and has a condition called central nuclear myopathy. And I just wonder if any of the doctors know of any treatment for that, or know of a doctor who we might contact to learn of a treatment for that condition.
Say the name one more time for us, please.
Centronuclear myopathy.
Chris seems to know about that. Chris, tell us about that.
Yeah, central nuclear myopathy is a congenital muscle condition that you're born with. Most people do pretty well, and it sounds like your daughter's a physician, so she's, even with the condition she's had since birth, she's done extremely well with it. There is no particular drug or medicine that we can do to reverse the treatment, but if you would like for her to see somebody, I would get you to contact your local muscular dystrophy association, because they deal in the treatments of all the muscular dystrophies.
So it's a variant of muscular dystrophy then, or similar
correct.
kind of condition.
Correct.
What would that manifest as? What would this young lady have?
She probably has some weakness in her arms and legs, difficulty getting up and down stairs, maybe some difficulty walking, difficulty lifting objects above her head or opening jars. Muscular dystrophies can cause a variety of symptoms, but usually it's mostly just the weakness of their arms and legs.
Very interesting. All right. Is that the kind of conditions that fall under the neuromuscular diseases that you would typically treat?
Correct.
It does. Okay.
Mm-hmm.
So I'm figuring that out a little bit better now. So we didn't get to finish the stroke thing, and I want to go back to that. If somebody comes in the ER and they have a bleeding stroke versus a clotting stroke, how do you diagnose them, and what do you do differently to treat those, Julian? Where did you send those patients?
Well, they get a couple of very quick X-ray tests, CAT scans, maybe an angiogram, a blood vessel test, and we try to do that within 20, 30 minutes of them hitting the door, because there's a potential treatment. Sometimes they have a hematoma, a blood clot in the brain, which needs to be removed. Sometimes they have the blocked artery where they need clot-busting drugs or an extraction of that clot up through the vessel. So there's some real miracles that we sometimes see with reversing these strokes.
And that's, both of those are things where minutes count, and you get the brain scan to figure out whether they need the surgery or the angiogram suite or whatever, right?
Yes.
Perfect. All right. Linda from Nicholas County is on the line. What's your question for us, Linda?
Well, I was diagnosed with essential tremors.
All right.
Now, why are they essential?
Why are they essential for you? All right. Chris, you want to take that one?
That's a good question. I've never really thought of why they actually were called essential tremors. Essential tremors are usually tremors caused by action. When people stick their hands out, they have tremors of their hands, and they also can have tremors of their head, their voice, their legs as well. And they're oftentimes run in families. And we do have medication treatments for that. The two most common medications we use are primidone and propranolol. Primidone is a barbiturate that's used, and propranolol is a common blood pressure medication that people use, and it's oftentimes treated. Now people who have, there are other medication treatments as well, but people who have severe essential tremors, there's also some deep brain stimulation that we can do as well.
Is this what Katharine Hepburn had, the shake kind of thing that she would have, or is that different?
I couldn't tell you much about Katharine Hepburn, so I'm sorry.
Showing my age here.
Yeah.
I'm showing my... All right. Well, thanks for the call, Linda. Next we have Denise from Monongalia County. Denise, go ahead with your question, please.
Yes, my nephew is 18 now. A year and a half ago, he had a brain tumor removed. 24 hours after surgery, he developed cerebral mutism. He does no physical therapy now, although he lives his life very normally. He's in college now. But how long will that last? Would it help with therapy? What can we do to help him, and what kind of hope can we give him that this is going to get better?
So this had developed after surgery, you said?
Yes.
Julian, you have any follow-up questions for that? Anything else?
I think she said it's been present for a year. Is that right?
How long?
Well, his surgery was a year and a half ago, and it happened like 24 hours after surgery.
Well, that's a long time, and if he's unable to speak, certainly the chances of getting that back as you go past 18 months really diminish. But I would encourage.
He can speak. It is just hard to understand, very mechanical sounding, not much volume, and he has problems with his balance and fatigue.
So it sounds like that's all part of the cerebellar function. It modulates and controls motor movement, including speech. And so the cerebellum part of the brain has a role to play. And about all you can probably do, I mean, he needs to talk to his doctors about it, but all you can probably do is therapy, speech therapy. And, maybe long term he would get better. He's still very young and probably needs longer to recover.
All right. Well, good luck with that, Denise. I'm glad he is getting somewhat better, and we wish him the best. All right. Do you have any input about that? Anything that you would, any medications that would help in addition to therapy or anything like that you would consider?
I don't think there's any particular medications that would make that better. Now, what I tell everybody who has a stroke or some damage to the brain is that brain disorders don't often always get better in a day or two. A lot of people expect a quick recovery. I always say it's like, look, you can't say about today or next week. You have to say 6 months, a year, maybe a couple years, and to get aggressive therapy as much as possible, because the brain can rewire itself, and people can get, if not totally back to normal, recover a lot of function. But it does take a lot of time and hard work on the patient and the therapist as well.
Have we learned any special types of stimulation that work better for rewiring your brain, or is it just normal interactions that seem to work best?
Just the body's healing process and Mother Nature and God and time. So.
Got it. That's very interesting. Julian, I have a pet thing in mind. Let's talk a little bit about helmets. You're an expert on brain injury and concussion. Tell me about what's good and bad about helmets.
Well, helmets are great, particularly football helmets we're talking about, for instance, because they prevent injury to the scalp, skull fracture, things like that. But the problem we have, I think now, is that the modern football helmet has become so protective, so large, so heavy, that in many cases it has encouraged players to stick their head in there. All of us humans have a brain which is floating in this bath of fluid called cerebral spinal fluid. So when the head suddenly stops, the brain is able to move inside the skull. And you could have a helmet with 6-inch thick padding, and it wouldn't change that immutable fact. So this is part of the problem with concussions, that the players stick their heads in there, and the brain shifts. It maybe reverberates a second time. And then a lot of these injuries are rotatory, where there's rotation, and that's a very common way of tearing brain fibers. And when that happens, of course, a football helmet can't prevent that at all. I've been advocating, I met with NFL Commissioner Goodell 3 years ago, advocated let's take the head out of the game. I think we have to. I think the velocities of the hits are too high. And I think that if you look at kinetic energy equals 1/2 times mass times velocity squared, the velocity number is so important in that energy equation that's why we got to take the head out of the game. We've got to make rules changes. We've got to enforce head hunting and head-to-head contact. We've got to maybe get the lineman out of the three-point stance so they don't have this obligatory head impact on every play.
Sounds pretty important and pretty complex. Now I'm going to let you tell us about one other thing. I'm fascinated by this, and the brain's obviously very complex. We actually have some other WE neuroscience people, and maybe you guys are in it too, on a television program that's on ABC tonight. Tell me what we're going to see there. Well, we've only got about 30 or 40 seconds left. So
yeah, we have a show where I think we're excited about it. We'll see. I haven't seen it, but ABC spent several months here in the spring and early summer. It's Secrets of Your Mind, Your Brain, and it'll show tonight on ABC at 10 o'clock. And it highlights some of the work done by our neurosurgeons, neurologists, nurses, anesthesiologists. They'll be inside the OR with us, so hopefully it'll be a good, positive thing.
Inside the OR, that sounds really good. Complexities of the Brain, Secrets of Your Mind, tonight on ABC. We've been talking tonight about brain issues with Dr. Julian Bales and Dr. Christopher Nance. Thank you both for being with us. If you'd like more information, talk to your family doctor or visit our website at wvuhealth.com. For Doctors on Call, I'm Dr. Joe Prudhomme. Good night and good health.
Join us again next time for another edition of Doctors on Call.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.